Hello community, Naomi Anderson here from Aged Care Ready. Welcome to our 11th session after a bit of a hiatus last week because of the Queen's birthday. Today I am joined by Dr. Sansan Xu. She is a neurologist who specialises in Parkinson's disease. Thank you for joining us, Sansan. Thank you.
Thanks very much for having me, Naomi.
So tell us a little bit about yourself and what you do and why you chose neurology.
So thanks again, Naomi, for having me. I think this is a great opportunity to have a discussion about Parkinson's disease, and no doubt a really fantastic resource for all the people involved in this group. I am a neurologist, as you've mentioned, with a special interest in movement disorders, of which the most common type is Parkinson's disease, which we look after. I've grown up in Melbourne and trained in Melbourne throughout my career. I have a number of roles now. So I work as a neurologist, both in the public sector at the Austin Hospital in Heidelberg, as well as privately at Cabrini Hospital as part of Melbourne Neurology. I'm also doing some further studies, in particular a PhD in Parkinson's disease through the University of Melbourne, specifically looking at one of the types of treatment for Parkinson's disease called deep brain stimulation. I chose neurology, I suppose, for a number of reasons. In terms of firstly, I guess I enjoy the type of medicine that neurology involves, especially movement disorders. A lot of the diagnostic, interest in movement disorders is still there, in that we really need to get to know the patient and their family to know what's going on. There isn't a magic blood test or brain scan that we can perform to make a diagnosis. So I find that diagnostic process quite interesting. Probably the main reason that I chose neurology is because, unfortunately, we don't have a cure for a lot of the conditions, but it means that we then get to keep our patients and get to know them and their families for a long period of time, and really, look after them throughout the duration of those conditions. And because of that, we tend to work in a big team as well. So along with other doctors like psychiatrists or geriatricians and neurosurgeons, we also work very closely with other health professionals like nursing staff, physios and occupational therapists. So I think that makes the job quite versatile, and that's what I enjoy about it most.
Beautiful. So before we get stuck into it, for those who are watching us live, you can ask questions in the comments section below. I will be looking over at the phone to see if anyone has asked any questions, and we can't actually see that you're here unless you give us a reaction. So make sure you hit the thumbs up so that we can see that you're there. And also, if you have any questions after the event as well, be sure that you actually reach out and ask for help. Okay, so what is Parkinson's, Sansan?
So that's it's a broad and complex disorder, but I guess at its most basic, it's a neurological problem that affects someone's ability to move. It's quite a common problem, and there's about 80,000 people in Australia that have this condition, and in particular it affects the elderly, so people over the age of 60. When we think about what's going on in the brain in Parkinson's disease, there is a lack or a reduction in a specific chemical called dopamine, and that is the fuel that helps drive the movement center of our brain. The condition itself, we unfortunately don't have a cure for, so we know that this dopamine problem continues to progress over time, though overall it's considered as a slowly progressive condition that changes, at a reasonably slow pace over many years. In terms of the movement problem itself, so it can really vary from person to person. So a lot of people think of Parkinson's disease as a tremor problem, but that can probably not affect significantly at all about a quarter of people who have Parkinson's disease. So some people might have problems with their walking or their hand movements or stiffness and slowness. And they some of the quite varied, I guess, presentations that people with Parkinson's disease can present with.
Yeah. And you mentioned the tremor and things like that as well. Just because somebody has a tremor doesn't necessarily mean that they've got Parkinson's automatically. I think there's that misconception as well out in the community that, oh, you know, I've got a tremor, that means it's the end of the world. But no, it's not always Parkinson's related.
Absolutely. That's a really good point, Naomi. So not all people with Parkinson's disease have tremor, and vice versa as well.
Yeah. So in terms of your role as a neurologist, how does that support Parkinson's, or how does that work together with Parkinson's? What's your role in that?
The neurologist has a number of roles in Parkinson's disease. Initially, the neurologist is fundamental in making the diagnosis of Parkinson's disease. With Parkinson's disease, as a lot of movement disorders, there is no magic test. So in order to make the diagnosis, we ask a lot of questions and we rely both on the patient that we're seeing, but also family members or friends and their accounts of what's changed. We also need to examine the patient, so look at the physical signs, and often it can take a number of visits before we can make a definitive diagnosis of Parkinson's disease, because it relies so heavily on the history and examination of the physical signs. After the diagnosis, we're involved in, I guess, the big umbrella term of management of Parkinson's disease, which encompasses a lot of different factors. So because in particular, I think it is a progressive condition, I think the neurologist has a really important role in informing the patient and their family about the condition and educating them, as well as linking them in with specific support groups, which can often be locally found. Like, for instance, in Victoria, Parkinson's Victoria is an excellent resource for a lot of patients and family. And though there is no cure for Parkinson's disease, it's certainly not doom and gloom. There is a lot of treatments that we can offer that can improve patients' function and quality of life. The initial treatments that we can offer are often tablet forms, and they work to increase the level of dopamine, so that chemical that's reduced in the brain, to improve people's movement. And the other thing that we really do encourage, I guess, as a neurologist, is that role of coordinating a multidisciplinary team. So in Parkinson's disease, we have a lot of evidence that exercise therapy can be really helpful, and early exercise therapy is really important. So the neurologist often has a role in coordinating a team of physiotherapists or speech therapists or occupational therapists and nursing staff who can deliver this multidisciplinary treatment in terms of managing the Parkinson's disease.
Sure. So in terms of the symptoms, we mentioned that sometimes they get the tremor, but what other symptoms do they have, from early symptoms right through to the end stage?
As we've touched on already, Parkinson's disease symptoms can really vary from patient to patient. And they also change a lot in the same person over time. Early on, often the movement, or what we call the motor problems, can be quite the main issue from the patient's perspective. They can include tremor, which can affect the arm, the leg. It can also affect the head or the chin, any parts of the body really. And there is also slowness and stiffness. And how that can manifest is, you might notice that people are slower in their walking. They might take smaller steps and shuffle. Some patients will have a stooped posture. They might even describe things like problems with the handwriting. It could get much smaller. Family members or friends might notice that they're less expressive in their face, or that they're a bit more difficult to hear when they're speaking. People also complain about, difficulty getting out of the car or rolling around in bed because of that stiffness and slowness. However, in addition to those movement problems, which occur early, there are also non-movement problems, or what we call non-motor problems, early in the disease. And they are slightly unusual. So people often, wonder why we're asking them these questions, but it's because they offer us clues that this could be Parkinson's disease. And they include symptoms like a loss of smell or a lack of smell, or constipation. So people who might, in recent years have noticed, my bowel movement's been really regular, but in the last few years I've become more constipated. And there can be sleep problems as well. So there's an unusual, sleep problem that we call REM sleep behaviour disorder. And essentially REM sleep is when we dream, and usually our bodies are paralysed, but in REM sleep behaviour disorder, you actually act out your dreams.
Okay.
So we ask odd questions often to the spouse of the patient and ask, do they accidentally hit or punch you in the middle of the night, or do they fall out of bed? And that's the reason we're asking those funny questions, is that sometimes there is this sleep problem which is quite strongly associated with Parkinson's disease.
Yeah.
Now, later in the condition, things do change a fair bit as well. So those early problems may not be the main things that bother people. So you can have falls and problems with your balance. In addition to the speech being softer, you might actually have some swallowing problems. So problems with, coughing easily when you're trying to swallow things, including the tablets. And then there could be other sort of non-physical or non-motor symptoms as well, like problems with urinating. So some people can have a lot of urgency when they need to go to the bathroom, or incontinence. Sometimes you can have high or low blood pressure problems, and sometimes it can affect your thinking, your clarity of thinking, which can be a big factor in terms of being able to remain independent with Parkinson's disease.
Yeah, that was actually one of my next questions. Can Parkinson's affect cognitive function? Can it lead to dementia, or is it more just cognitive impairment, I guess?
Yeah, so that's a really good question. And again, the answer to that changes depending on the time course of the disease. So early on, a lot of people do complain about sort of a fuzziness in their thinking, or difficulty concentrating, slowing down of their thinking, not being able to respond as quickly as they want to. And that can sometimes be related to a lack of dopamine, that chemical in the brain. And so that can sometimes improve with taking medication. In addition to that, mood is a big issue early and late in the condition. So if you've got anxiety or depression and low mood, that can really affect your cognitive function. Then later in the course of disease, so usually many years after you've been diagnosed, some people can get a more permanent cognitive impairment and even dementia. And the type of dementia, there is a lot of overlap in terms of the symptoms with the other types of dementia. I know Dr. Zanker spoke previously about dementia, of which the most common is Alzheimer's disease, but the type of dementia in Parkinson's disease can present slightly differently, in that though you can have memory problems, it may not be the most prominent issue. So you might have problems with your attention and organising or planning things. You might have problems finding the right words, and that can be very frustrating. Often, tasks that your spouse or family members used to allocate to you, like paying the bills, they might be concerned about you doing because of those poor planning and organisation skills. And then some people can even develop visual hallucinations, so seeing things that aren't there. And the interesting thing about them is often in Parkinson's disease, a lot of patients may not be bothered particularly by the hallucinations. They know that they're there and they sort of are aware of them, but they might not be significantly distressed by them. So those are clues that perhaps there is a more permanent cognitive problem that could be emerging.
Yeah. You touched on earlier about some of the treatments that are available and medication and that sort of thing. Can we delve a little bit further into what types of treatments are available for Parkinson's?
Yeah, sure. So even though there is no cure for Parkinson's disease, there is really a broad range of treatments that throughout the course of the condition that can really help the symptoms. And the treatments do differ depending on the stage of the illness as well. So early in the condition, we do use medications, as you mentioned, Naomi, and the medications are usually tablets. And these tablets increase the amount of dopamine in the body. You might have heard of levodopa or the brand names like Sinemet, Hinson or Matapar, and they get converted to dopamine in the body, and they are often taken multiple times a day and can really improve those physical symptoms. So the movement, the shuffling, the walking, sometimes the voice and the handwriting as well, and sometimes the tremor. The other really important component of early treatment is exercise therapy. And so we have a saying that you use it or lose it, and that's particularly relevant for Parkinson's disease.
Absolutely.
So again, the approach is not one size fits all, so it needs to be adjusted depending on how active that person is usually and the severity of the condition. But there is a lot of evidence to support Parkinson's disease specific exercise programs that address sort of cardiovascular health, and high intensity exercise is encouraged, especially early in the condition. But then later in the condition, the types of therapy actually change depending on the issues that arise. So, for instance, there are specific programs for walking or balance or speech and swallow that are really helpful. And these interventions by the physiotherapist and speech therapist are often even more effective than the medications that the doctor might give you for these specific problems. Now, in terms of, I suppose, later in the condition, what may happen is the tablets, when they do work really well, but because often you're needing to take them multiple times a day, you can get fluctuations in your movements and what we call your motor state. And there's a number of reasons for that, but it's likely related to the fact that ultimately you're not getting the dopamine replacement at a continuous rate throughout the day. So it's going up and down, and therefore sometimes you're great and sometimes you're really in a bad way in terms of moving really slowly, tremulous, and stiff and in pain. The other thing is you can get really high levels of dopamine, and then you might see people can get side effects from the medication when they're wriggling around a lot, and we call that dyskinesia. So when that happens, we offer more advanced type of therapies, and we call these therapies device-assisted therapies. And usually these aren't required until about 5 to 6 years after people are diagnosed with Parkinson's disease. So that duration really can vary from person to person. And there are 3 main types of these device-assisted therapies. So the first 2 are dopamine medications, but they're not delivered by taking them as tablets. So one of them is called apomorphine, and that's a liquid that is given through a little needle underneath the skin in your abdomen. And so you can get that as an infusion throughout the day, and it gives small amounts of the medication continuously through the skin in the stomach or in the abdomen. The second type is called duodopa, and that's a type of gel, and you can get that delivered directly into the small intestine. So it does involve a a small procedure where you need to get a tube put through your stomach into your small intestine, and the gel gets delivered continuously into the small intestine, where it gets absorbed directly into the bloodstream and then to the brain. And then finally, there is a type of surgery called deep brain stimulation surgery. And that involves a type of brain surgery where we insert some electrodes into the brain, and that's connected to a wire that's all under the skin, and then connected to a battery that's on your chest here. And that delivers stimulation into the brain and tells it to stop doing the things that it does to cause the symptoms of Parkinson's disease. And so that's a procedure called deep brain stimulation therapy. And so those three therapies are what we reserve for people who've had Parkinson's disease for a number of years and who the tablets do work on, but just not all the time.
Yeah, that's interesting. And as a nurse in aged care, I have seen all types of those therapies that you've mentioned, and you know, I've seen them work really, really well as well. So it's good to know that people like yourself are out there and doing the research and helping people with Parkinson's, especially with the symptom management as well, because I know that can be quite distressing for a lot of people.
Absolutely.
Yeah, especially later on down the track. Now, I have one more question from my list, and I can see that there are a number of questions in the comment section. So now would be a really good time to pop them in there so that we can get to them. If you're wanting to ask something of Dr. Sue. Now, and I guess this is a common question that you'd probably get when you see some of your patients. What is the common life expectancy of someone with Parkinson's?
So, Naomi, that is quite a difficult question, but it is the question that a lot of people do ask, and therefore it's a really important question. So as with a lot of conditions, it does vary from person to person. I guess as a broad rule, we say that Parkinson's disease is a slowly progressive condition. So the changes we see do not happen within months or even 1 to 2 years. There is a slow decline over many years. How long that is depends on a number of factors. It can depend on the patient themselves, but it can also depend on the age that you get Parkinson's disease. So in a much smaller number of people, some people get Parkinson's disease when they're quite young, in their 30s, 40s or 50s. And the duration of that condition is much longer than if someone were to be diagnosed in their 70s or 80s. As a general rule, we tend to say that, the Parkinson's disease symptoms tend to be more manageable in the first 5 to 6 years, where you have a honeymoon period on the medications. And then at 10 years or so, you may start developing some symptoms that can, I guess, be a warning that it is in the more severe stage of the condition. And the things that we look for are if you're falling over all the time, if you do develop problems with your thinking, so dementia, for instance, that we've discussed in the past, if you have a lot of hallucinations, and if you're just not able to do all the things that you used to do because of those reasons. So, going to the bathroom, getting dressed yourself. So if you're losing those functions and you're needing, for instance, to go into an aged care facility, then often that can herald the very later stages of the condition.
Yeah. Okay. So it's essentially asking you how long is a piece of string.
That's right.
Everyone is different.
Yeah. And I think the other factor to consider is because people do slow down when they're a bit older. And some people, rightly so, may not want to see doctors for certain things, and they just I guess they're not bothered by the symptoms as much. There is also a delay in the diagnosis in some people of Parkinson's disease. It can sometimes be misinterpreted as a part of aging. We're all getting older, we're all slowing down. So that can also change how long someone may have actually had the condition for. And those are all factors that make it a bit difficult to know how, the duration of the disease itself in somebody.
Yeah. Okay, so I'm going to throw to the audience in the community now. So if anyone has some questions that they'd like to ask San this evening, now is the time. I have 2 questions for you so far.
Sure.
Amanda asks, is it hereditary? My dad had it. He died age 91. He had it for about 10 years.
Okay, sure. So, Amanda, that's a really good question. And again, a question that a lot of family members who have cared for or looked after someone with Parkinson's disease are very interested in. So Parkinson's disease, the most common type of Parkinson's disease is what we call a sporadic Parkinson's disease. So that essentially means that we don't really know what causes it. And this is the type of Parkinson's disease that tends to occur in older people. So who are diagnosed over the age of 60. And by far, that's the more common type of Parkinson's disease. Now, what causes that type of Parkinson's disease is probably quite a complicated process, in that there are probably things in the environment that might increase your risk, or things in your genes. However, the biggest risk factor in that cohort is really being older. Now, there are, however, a small group of patients who have what we call genetic Parkinson's disease. And they tend to have Parkinson's disease diagnosed when they're much younger. Okay, so it can be in their 30s, even in your 20s. And in these patients, they often have other family members, often more than one, that have had Parkinson's disease, and also at a younger age. Now, this type of Parkinson's disease is often slightly different to those that we more commonly see in the ageing population, in that often these patients live with Parkinson's disease for many, many years, so into their 70s and 80s as well. And so that timeline that I talked about of 10 to 15 years is very different in this cohort. But much more commonly, I would say, Amanda, is that in someone who's diagnosed over the age of 60, because Parkinson's disease is so common in that age group, the main risk is really that you're a bit older, and therefore the genetic elements are probably less prominent in that case.
Yeah, okay. And then I have one more question for you from Sarah. Now I'm going to put a bit of a caveat on this question, because San, you don't know this person and you haven't assessed their needs. So obviously, being in this forum, San can't give diagnoses or advice. It's just information. So Sarah says, I suspected my dad had Parkinson's and took him to the neurologist. As you said, there's no test that is definitive. He was started on Parkinson, and within about 6 weeks, he's made a huge improvement. Does this mean it is Parkinson's?
So, yes, I guess this is a slightly tricky question to answer in this forum, but of the problems, that cause movement movement symptoms or difficulty with walking and or handwriting or speech, often the most common cause is going to be Parkinson's disease. And one of the, supporting criteria for the diagnosis of Parkinson's disease is how it responds to medication. And so we often do start medication not only to help treat the symptoms, but also to give us a clue as to whether this could be Parkinson's disease. So certainly if someone has a dramatic response to Parkinson or another form of dopamine type treatment, then that provides a lot of supportive evidence that this may well be Parkinson's disease. However, there is a slight caveat to that, in that not everyone with Parkinson's disease responds brilliantly to these medications. So again, it may be about 20% of people that may not respond that well, yet still have Parkinson's disease. However, when there is a response, it's really helpful for us as doctors to say, look, that's providing really good evidence to support a diagnosis of Parkinson's. But as you say, Naomi, we do need to look at the big picture in terms of making a definitive diagnosis.
Yeah. And that was the last of our questions for tonight. Is there anything else that you wanted to add, Sansan?
I think one thing I'd like to say is that because this is a condition that does progress really slowly, but it does change over time, I think one of the really important things to do at the beginning is to inform and find out more about the condition and engage with those support groups. I think that they provide such a brilliant resource and are often run by staff that are really passionate about the condition as well, and can give you a lot of information locally about where to find good physiotherapists, good occupational therapists, and all these other important clinicians in the management of Parkinson's disease. So I would really encourage you to find out more information. So in Melbourne or in Victoria, Parkinson's Victoria, and there's Parkinson's Australia as well, to, I guess, inform yourself about the condition and know the treatments that are available, as well as find out about those additional support personnel that you might be able to engage early in the diagnosis.
Yeah. With, going off what you've just said there a little bit, I have been in contact with Parkinson's Australia, and I'm in conversation with them at the moment about getting them on a live session with us. So about what services they provide, what resources and support they provide to those families who are caring for a loved one with Parkinson's. So if that's something that you as a community would like to see, please do let us know, because that's something that I'm working on, and I think that would be quite valuable for our community. And similarly, I will be reaching out to Dementia Australia as well after our conversation with Dr. Zenka. So I think that's it for tonight. Thank you so much, Sansan, for giving up your time to have a conversation with me and give great value and show your experience to our community. We really, really appreciate that. And that's it for tonight, and we will see you, community, next week on our next live session. Good night.
That's my pleasure, Naomi. Thank you very much for having me.
Good night.
See you later.